And I just wanted to offer the kind of questions we put out there for her to answer. We're not advertising a product. We don't do that as Trio. However, Allomap is a product that this company and her markets, and that's going to be used as an example of how technology is moving in great strides and talking about a patient's ability to affect how a doctor looks at some of those advances in their lives. So with that, I'm going to transition over here to Herb's presentation. And Herb also has a video that we're going to get to at a certain point. So Herb, you're on.
Thank you. I'm awfully glad to be here, and I have to tell you, for the bit of time that I had to share with you all this morning, late this morning, and over lunch, it really is a fascinating group of people. You guys are
we think it's fascinating, don't we?
Yeah. It's inspiring as to what some of you have been through, how you faced up to those challenges, and how you're now trying to give back to the communities that benefited you. So I applaud you for your efforts. This is going to be a very short presentation. As Jim and I have discussed, we really don't want this to be a commercial. It shouldn't be. I just want to explain a little bit about maybe who I am. That'll take just a few seconds, and we'll go over the company, the product itself, and I'd quickly like to get into some videos. Some of the people in that video you might be familiar with, who have experienced Allomap and the benefits of the product. And then I'd like to open up the floor to the questions and discussion around the very end, which is what we'd like to do in partnering with organizations like this to move the adoption rate forward. We think this product offers a lot of value. We can talk about where that is through the presentation, but we certainly would like to hear your feedback about how we'd like to proceed going forward.
You got control right there, the buttons to the left and right.
Okay, just to explain a little bit about XDx, it's an expression diagnostics company. Genetic expression testing really has a direct line to the Human Genome Project, where they identified all of the genes in the human genome. Those genes were mapped around this product for heart transplant patients to test whether or not there is rejection. I could go through all of the science and the math, but I don't think that's appropriate here. Suffice to say that a lot of the research in mapping the genome resulted in a genetic expression product like this one. XDx, when you boil it all down, and I joined the company in March of this year, did some consulting work with them before that. I actually decided to join as a more full-time consultant in March, and I joined full-time working for the company in April, around what I picked up on as the value for an organization like this. It has to be about things like quality of life and patient safety. Yes, it's a for-profit organization. Yes, there are investors that benefit from it. But all of the products, and I've been in the healthcare industry specifically in what they call in vitro diagnostics for close to 30 years, all of the products that really attracted me were ones that provided a high level of patient benefit, a high level of positive outcomes. And if we could attach an economic profit to that, then all the good, all to the good. That's not always the case in healthcare. A lot of products are marketed and may not necessarily provide the true differential benefit that matches the economic profit that they make. I, for one, am attracted to ones. Small company, it's a startup, still private, funded by venture capitalists, the most famous of which is Kleiner Perkins. Kleiner Perkins has done a lot of work in the healthcare space. I think the most famous company that it funded was Genentech, which has done a lot of good work. They made a lot of money as well, but I think they've done some good work, and the venture capital model is a value. Commercialized products since 2005, less than 90 people. The company is based in Brisbane, which is just south of San Francisco. Beautiful area. The test is a non-invasive, simple blood draw. It was cleared by the FDA in 2008. Now, I think one of the interesting things about XDx and this FDA clearance, the business model that they use is very much like what we call a reference laboratory. In the IVD business, you have some companies who put together a package that is a system and dedicated reagents. That's the favorite economic model because you have single-use reagents that are attached to a system. The fastest way to market for a company like XDx was to create more of a reference lab model where you basically would take a sample, blood sample, and you would process it in a central location. LabCorp, I think, is in Quest, some of the more famous reference lab business models. This is a smaller, more focused organization working on one product. 25,000 commercial tests performed to date in over 100 transplant centers. The Image Center multi-center study, I think, is another effort by the company to validate the performance of the product. Another thing that attracted me to XDx was the fact that if you're going to be in the business of marketing a product that was heavily based on generating significant positive clinical outcomes, you needed to continually validate the product. IVD companies traditionally had built their product line simply on testing against what they call the gold standard or another product that is like it. They've taken a step further and they've invested in significant outcome studies that look at the performance of the product and the impact that it's had versus what's been used, which is EMB, endomyocardial biopsy, which many of you are familiar with. Allomap simply comes up with a score. So you send in the blood samples processed close to the patient in the center. It goes into the Allomap facility, shipped all the way across the country overnight to San Francisco. 95% of the results are available within 24 hours from the receipt of the sample. Basically, it tells you at that point in time that you're not rejected. That's what the FDA claims. 20 to 35 biopsies are required for heart transplant patients throughout their life. Okay, it's an invasive procedure. It's surgical. You know, a catheter is taken through the brain to extract pieces of your heart. That's analyzed on the pathology slide, and a result is provided. It's variable and subjective. The slide is actually read by a pathologist. There are studies that we can familiarize you with that show that there's great variation between pathologists. Some read it one way, others read it another way. That variability with a product like Allomap is more or less limited. But you know, it's as I go through some of the data when we talk in more detail about EMB, endomyocardial biopsies, it's not to say that there's a high degree of danger, but there is some danger. And the only point that I'd like to make here is that when you compare Allomap to biopsy, it compares favorably. When you look at the risk, it's not just the surgical risk, it's also the analysis of the sample itself that needs to be considered. It's an expensive procedure, but as many of you know, calculating the cost of something in the U.S. healthcare system is not necessarily an easy thing to do. So the costs range anywhere from $4,000 to $20,000 per procedure. One of the things that I'd like to bring to XDx is really looking at the economic cost, the true economic cost of EMB versus something like an Allomap. But one of the problems that we'll face up to is actually pegging what that cost is. That's just the reality. These are just some of the things that can happen. You can pierce a hole in the heart wall. You can cause irregular heartbeats, puncture blood vessels. You can cause or stimulate blood clots, bruising, reaction to anesthesia. There's a 1 to 3% complication rate. If you're looking at 20 to 35 EMBs over the course of a heart transplant's life, multiply that times the thousands of transplant patients that exist. You know, there's a There's a large number of complications. That's just a reality.
Same with patient's life, you're typically talking the first 2 years.
First 2 years.
So it's sort of concentrated.
Yep.
I had a friend that.
Yeah. We'll know somebody that had that complication.
It's not it is certain. It's not without precedent. We've also begun to explore some research that shows that obviously the more you do, the more scar tissue develops and the riskier it becomes, which is the reason that you want to look at an alternative like Allomap. Also, there's a radiation exposure that is not insignificant. This is just a diagram that shows kind of the procedures. We have a huge testing capacity. It's a CLIA certified laboratory. I've known the person who manages that laboratory. He's a VP of operations and R&D for a number of years, very precise fellow, very process oriented. It is a very high standard laboratory, gold standard, obviously. Results sent to clinician, as I said, within 24 hours, 95% of the time after receiving the sample. I want to talk about the image study in this slide just for a minute. It was done at 12 preeminent centers around the country, 602 stable patients. When you talk about the statistical significance of that, when you look at the number of heart transplants patients that there are, this is a very significant study. It took over 5 years to complete, over 3,000 visits. In fact, there was a gentleman here that was part of that. It's still?
Yeah, I don't know if it died or...
It's still on.
Can you hear me?
I mean, I can hear you, but not from the speakers.
Not from the speaker.
Got battery.
We can hear you.
right.
But
Is my voice?
What kind of
well, louder?
batteries does it
Do you
take?
hear it?
Can you hear me?
Yeah.
It's okay? Randomized over non-invasive, or randomized over the Allomap versus the EMB. Primary endpoints were death or graft dysfunction. I think the most important thing in the promotion of a test like this is the fact that the study itself reaches the level where it can get into a prominent journal. The New England Journal of Medicine for us is the holy grail. The other one would be Lancet. So I've marketed tests that have had their major validation study in both journals, and I've marketed tests that haven't had the ability to get in those journals where the validation wasn't good enough. Definitely I prefer that you're able to get in the New England Journal of Medicine, or, can you hear me now still?
Yeah.
Or Lancet. Okay. One of the things that I note as an outcome of the study is the reduction in biopsies by 75%. Right? It's not something that we like to promote heavily with the cardiologists because of
business.
there are I'm going to say it this way, there are financial realities in the healthcare system that make it difficult for us to do. It's counterproductive. It's not the.
There's still catheterizations that they're going to do. They cost more.
We understand this one, Herb. Go ahead.
Been there and done that.
Yep.
Yeah.
These are all of the things that I think really provides XDx the high ground to drive toward a higher adoption rate. I talked about the Image Center study, but also the fact that the guidelines were recently approved, the CTAP guidelines late last year. So these are things that I think validate that this is not an experimental procedure, despite what some of the insurance companies have said early on. It's a real test. It provides real results, and I think that the fact that the studies have proven that and the guidelines support that certainly make that
I'm
case.
going to ask any question I raised. Don't be about the product. That's incidental to our conversation here, really. So talk to him later if you want to talk about how that works or any of the details or the reimbursement or anything like that, okay? We're talking here leading up to patient empowerment. So stay on topic in that sensitive with your question, please.
I understand why this test is being done for heart recipients because they have these biopsies, multiple biopsies. but even for other organs, I know when I became sick one time, I had a biopsy on my kidney. Could that test also, could that test replace biopsies on other organs? That, I mean, the biopsy usually wants to
the technology has been optimized for heart transplants and acute cellular rejection at this point. The plan is to move to other solid organ transplants and providing the same sort of expression testing there. Other technology will have to be an expertise, will have to be acquired in that effort, but that's certainly in the plans of XDx in the very near future. In fact, there's a meeting next week where we'll be talking about the very subject.
A question about the economics of healthcare. If the cost of this is significantly less, why don't insurance companies jump on it?
I can give you the experience that I've had over 20-year career where I was working specifically with these sorts of reimbursement issues with insurance companies. They're very data driven. They're very risk averse, as is the U.S. healthcare system. So, you know, it takes a long time before they can gather enough confidence so that they can provide a coverage decision that they're confident in. They also are motivated by profit. So, you know, they need to know that the economic trade-off is there so that, you know, the profit is appropriate. So here, I don't think, to be honest with you, that companies like XDx have done a good enough job in proving that, you know, the economic benefit is there. And it'll have to be a, you know, kind of a rob Peter to pay Paul situation. If you're actually in a healthcare system that is approaching 20% of GNP, if you're going to save money with new procedures like this, you're going to have to replace other procedures that are more expensive. You have to prove that.
So you would think the insurance company certainly would be an advocate for that because they're the ones saving the money.
Yeah, but you have to bring
Right?
you have to bring the data to the table.
What is the New England Journal of Medicine date? If I want to look at this way.
This article is from January of 2010.
Thank you.
Claude?
So how does a person get on to this program?
Can I move to the end of the presentation because
Yeah,
there's
I know
some
I'm
things that I'd like to talk about.
Good.
This is all where the testing is available. It's available around the country in all of the major centers. And overlaying that, there are draw sites where you do not have to be at the transplant center itself to get the testing done. You can actually go to a draw site, have the blood drawn. It can be sent processed, sent directly to XDx, and the result can be sent to the physician. These are the quality of life issues. I mean, I think I'd like to stop now and maybe go to the patient video.
Yeah. Ask the question when I move to the...
Any other questions?
Is it only in adults that you use it right now? It's not
15 years ago.
I can comment on Steve's question. I know I do the Allomap, and XDx is very workable, if that's the word, with the insurance companies. And my insurance company, whatever they pay, they take. No questions asked. So there is that working.
I will say this. One of the things that impressed me about the company, and it's not necessarily to their economic benefit, no patient has been denied an XDx, an Allomap test. So, you know, we will run the test and we will take the chance of collecting the reimbursement on our own if we have to.
They'll contact you and have you talk to the rep, try and help them collect, but they don't come after you for payment if the insurance doesn't cover.
Really, one last question before we go to the video.
Yeah, if the Allomap does signify rejection, do they still have a biopsy to confirm that?
Yes.
Okay. So it doesn't eliminate just so
No,
anyone
no,
has that misperception?
no.
The way I've heard it from our center, it indicates a risk
Right.
of rejection, therefore. So if I can borrow your microphone.
Sure. The indication is for stable patients.
Okay.
Okay, so if you are in that area where you're stable, that's when the benefit of Allomap versus EMB.
very painful and very psychologically stressing test that I didn't recover from very well. I would be bruised and painful and in pain for literally weeks after these tests.
So it allows me to avoid losing a day of work because I still work full time. When I go in for a biopsy, I've got to go into the hospital as an outpatient first thing in the morning. My transplant center is a fair ride away from my home. Yeah, I lose a full day. My wife loses a full day at work as well. But the big thing for me is to avoid the procedure as many times as I can because I know what can happen.
So every time I had to go for a biopsy, which this time was like almost a month before, I had to go through the grind, and it was a 2-day recovery for me. It must have been 2 or 3 biopsies in a row that they must have hit the same spot because all of a sudden I went in for the biopsy one day and the doctor's listening to my heart and says, "You got a hole in you."
Allomap testing has just been so easy. My doctors absolutely love it. It really goes hand in hand with other standard tests that I just have to have done. So it's nothing that takes me out of my comfort zone.
So the real question that I posed to you was a patient who believed in...
To the presentation, right?
Yep. Oh, I'm sorry.
At the end, there was just a... Our challenge is that there are no national heart transplant recipient organizations. So one of the things that I looked at when I joined XDx was to partner with as many regional organizations as I could. The idea is to talk to patients. If we're going to move the adoption rate up, and I think there is some value in doing that, we have to influence the physicians mainly the physicians who make the decision. One thing that I heard often, and I did like a 4-week travel in the field visiting as many centers as I could, those who did not use Allomap as aggressively as others always said that there were access problems or if the patient asked for it, they would be willing to prescribe Allomap. So for me, it became important that we at least educate patients so that they ask the right questions. Okay, so I'm not saying that we should get in the middle of the the doctor-patient relationship, but I think we should encourage an educational process and thereby help the discussion along the way.
I think that goes back to the same argument, though, or rationale that you're your own best advocate when it comes to your health care in every phase of your treatment when it comes to being a transplant recipient. And this is just one other example of that. If you feel like there's something, a need of yours that isn't being addressed, you need to bring it up with your transplant team and be assertive about talking about it or asking questions. And a lot of times, I think that this is just an example of that. You say, well, Doc, how come Lou's getting this blood test and you're still digging in my neck here and taking heart tissue? I know a guy, Lou, that I met at the transplant games, and he doesn't have them. How come I still have to have it? And to question that, I think, is a good thing, because otherwise, sometimes people just do business as usual unless you stop and question them, make them think, and make them consider those kind of things.
And we're also interested in building the dialogue with not just patients as yourself who have experienced Allomap, but non-Allomap patients. Marketing really is ultimately about segmentation. And I think much of our messaging really needs to be focused on those who aren't familiar with the test and the benefits of it. And again, this is about education. We're not trying to get in the middle of the doctor-patient relationship, but we provide the right kind of education such that they ask the right questions. And then it's the follow-up question. You can't just ask one question and then have the physician who might not be as in favor of it as some others. They might come back with some resistance. We'd like to educate them on how they can ask the follow-up questions and move the discussion a little bit more aggressive.
So just to follow up on what Merle just stated, he's 100% correct. I only started that because I asked for it, pushed for it from the doctors at Columbia Presbyterian. This particular team, I had half were for, half were against, and as you know, and I pushed for it, and I finally got into the program. And when I moved down to South Carolina to MUSC, they were automatically going to start me on a schedule for biopsy. And I said, "You guys do Allomap here?" They said, "Yeah, we do." I said, "I want to do that." So you do have to, like Merle said, if you don't speak up, nobody's going to walk up to you and say, "Hey Lou, do you want to do it?" You got to say, "Listen, I want to do this," and don't accept no for an answer.
This plays into my own reaction to many TV commercials that we see all the time, advertising these products, and I've always questioned myself, so what? I mean, the doctor's prescribing something. Is he really going to have me come in and say, "By the way, I think I ought to get this one"? I mean, the average doctor, and thank God they're not my kind of doctors, would say, "I'm the doctor, I'll tell you what to take," type situation. And so my real question when we started talking was, does the patient have the power to impact? And we've been hearing some answers to that with some examples, close your advice. And by the way, in the interview coming up, the doctor addresses some of those issues too. And I think there are different kinds of doctors. There's some that think they're GOD, right? And there's others that welcome the opportunity for an enlightened patient to come in and have a conversation about things. And they will steer you away from something if it's not the right for whatever. But what are the patient empowerment concerns do you have, or resistance do you have to being an active part of your treatment program in that sense? Jamie?
I think the fact that those commercials have been on as long as they have, it's testament to the fact it's working.
They must think it does.
I've seen news programs, it's been a few years, but where they actually go in undercover and ask for these specific drugs, even though they may not necessarily need them, and they're getting.
What did they show in that particular?
They showed that if these doctors are very influenced, and if you go in and ask for something specifically, there's a much higher percentage you're going to walk out with it.
I'm sure that, like in Lou's case, a doctor that's not proactively promoting it, at the same time reactively addressing it, over time, again, if they're not the surgeon that's losing the money by not doing the procedure correct, is going to gain more confidence and maybe be suggesting it to patients in the future. So you have two impacts, your own treatment and probably over time the doctor's reaction to this as they get more comfortable with it.
Now, I should say as a representative of industry that companies have abused the education process. These commercials that you're talking about are really in effect an education process. And what some companies have put in these commercials, I think have been over the top. I think it's the job of a company like XDx to provide a balanced view of what information the patient needs to engage in that dialogue with the physician. It shouldn't be over the top. It shouldn't push in one direction or the other, but it should provide information that's in and of itself should explain the situation and encourage at the end the patient to have a conversation. That's what we're looking for.
What?
It's got that word up there I don't like. Patient. I am a recipient.
The recipient.
You go out talking to recipients, ask them if they're a patient or a recipient, and see if they won't change that word for you. Okay.
Change it to recipient. I missed that part of the program.
Up until they get their transplant, they are truly a patient. Yeah. But after that, we're out there in life as a recipient.
I will make a note of that.
We're just somebody who got sick and now we're okay.
Yeah, exactly.
Yeah.
We may become a patient again at times, but
I will allow my doctor to call me a patient and a coordinator, but nobody else. I am not a patient.
Duly noted.
And he has no patience.
Especially being called a patient.
No, I have a lot of patience. You know, I waited a long time to say that. He got through the whole thing without me.
Does anybody else have another question while we have her here? This is it. Steve?
I think it'd be interesting to hear about this Mike Shopper's meeting. We've got a fair amount of new hearts.
Just what I was just going to say then, Steve.
A lot of people who don't have hearts transplants, but just are interested in what's going on in general. So if you'd care to come, we'd love to have you.
In closing, let me offer that experience then, because we've had a number of chapters that XDx has been very supportive of coming out, providing a meal even for a chapter meeting, and to be able to present their story. And what I caution them when they come to that is, we're not here as a product endorsement, but talking about technology, and Allomap being an example of technology is certainly fair game. And they've done some great work. I think we had Alicia up there in Philadelphia, for example, a presentation we thought would last half an hour. Lasted an hour and a half because of so much interaction with her, and she did a great job. She covered, at that time, she was in a job, she was covering the entire East Coast. And she's based down here in Washington. She drove up our meeting, and I gotta admit, it was too small a meeting, but hey, she did it, and we recorded it, and we make it available to all the chapters. So I encourage you, through XDx, to find out who is in your area. They're looking for audiences like yourself to come out and help support, share the message, and to give that education. And they do a great job. Herb, I compliment you for the staff out there. I know you're fairly new, so you didn't bring them on, but hang on to them because they're doing a good job out there. And every time I turn around, I run into their trail someplace, including here trying to get the nation's capital to have a meeting that they want to sponsor, bring a meal to it, etc. We're trying to work with them to do that. So by all means, great idea, Steve. Reach out locally and maybe give you the contact at one point for you.
Jim has my contact information. I can certainly leave my card for as many of you as I can. Please contact me. We'll make sure that we support this sort of activity.
One other quick question before you leave. What were you doing consulting-wise before you got into consulting with XDx?
I was a commercial general manager for a large IVD company, mainly in the infectious disease area. It's called BioMerieux. So we did a lot of work in the microbiology.
I've got to believe you're developing quite a passion for the impact something like this can have, and that's why you joined the company.
Yeah. It's the ability to see and work with patients directly. You didn't have that opportunity as much on the microbiology side.
Herb, I thank you again for taking time out of your busy day to come and share with us. Make sure I don't forget this. And I have for you, thank you from Trio.
The sandwich. No.
I was going to give one about making a choice in life, but since he's just done it, let's not overdo that. But here's a book, A Treasury of Inspirations. For each day when you get going, I don't know that you need that, but certainly it's helped many of us, and I'm sure it helped your days.
I hope I can stay a little bit longer.
You're welcome to stay as long as you'd like.